Most people think that this is dry skin, but no amount of moisturizer is going to make it better. Many people come to me after thinking that this is a pimple and it's not going away. It's been 8 weeks, it's been months, it's not going away with typical acne treatment. And I've even had patients think that this was ringworm. They're treating it with over-the-counter antifungal medications and it's not going away. And that is because all of these things have one thing in common. They're all basal cell carcinomas. I'm dermatologist, Dr. Abby Waldman. I am also a Mohs surgeon, and my specialty is skin cancer. In honor of May being Skin Cancer Awareness Month, we're going to discuss every single thing you need to know if you or your family member has been diagnosed with basal cell carcinoma. So first off, how is basal cell carcinoma diagnosed? I've shown you some of these examples of how people present. It's usually a rash or a pimple that is not going away in about 6 to 8 weeks. They usually present in sun-exposed areas. That being said, they can present in areas that don't see the sun, like the genitalia, the feet, and areas you might not be thinking about, like the eyelid, the scalp where you can't see well, inside the ears. They may be itchy, painful, bleeding, or just growing. So if you have lesions like this, it's key to be seen by a dermatologist or physician who can evaluate the lesion and see if it needs any further workup. Now they might look at it and say, nope, totally normal, normal mole, normal rash. But if there's a suspicion for basal cell carcinoma, often they'll look with a dermatoscope. A dermatoscope is a special magnifying glass that can see through the top layer of the skin and see some patterns that look like basal cell carcinoma. It's why they send us to school for so long. You learn how to sort of recognize these certain patterns in order to help make the diagnosis. Oftentimes, what will follow is a biopsy. Now, the biopsy might be a shave biopsy. This tool is used after local numbing medicine to take a small sample of the basal cell. If it's a deeper lesion or if there's a suspicion for melanoma, they'll use a tool that actually takes a deeper area. This is called a punch biopsy. Well, the dermatologist will numb up the area, take a little core of the lesion and either put in a suture or some material that controls bleeding, and that will heal on its own. Less commonly used are excisional biopsies. That tends to be used more when there is a suspicion of melanoma, but sometimes your dermatologist may be wanting to get the whole lesion out that same day, in which case they'll actually take the lesion that you're concerned about, plus a little bit area around it, a little margin, and take an area around and underneath to remove the entire thing. And either stitches will be put in afterwards or no stitches will be put in and it'll be left to heal on its own. Now, what do these different biopsy methodologies do? So the nice thing about the shave biopsy is it only takes a very small sample. So let's say it's not a cancer, you don't end up with a scar or any significant scarring by just taking a very small piece. So that's the benefit of using the shave biopsy or even a very small punch biopsy tool. What's the downside? It's not treatment. A lot of patients come to me saying, well, I already got treatment by my dermatologist. They numbed it up and they took a little piece. That is not the treatment. And I think it's very frustrating for people sometimes to realize that even after they've done that first step, you need a second step, which is treatment, which we will discuss shortly. So benefits of a shave and a small punch, minimal scar. Downside, you are going to need more treatment. If the dermatologist does remove the lesion at the time of the biopsy, the benefit is that you're usually done after that and no further treatment needs to be completed. However, obviously, if it didn't end up being a basal cell carcinoma, you've ended up kind of with a bigger scar area than you might have bargained for. Now, when people hear the word cancer or skin cancer, you may be worried that basal cell carcinoma has spread inside your body. The good news is that these skin cancers do not like to go inside the body. They don't like to spread to the lymph nodes. They don't like to go to the lungs or the brain or anything like that unless they have grown very, very large. So the vast majority of these are going to be locally destructive tumors, meaning if you leave them, they're going to kind of eat away at the skin, eat away at the bone and the cartilage and anything they come into contact with. And so just like a cavity where you want to treat it early before it causes problems, similar to a basal cell carcinoma, you want to treat it when it's as small as possible before it has the ability to kind of eat away at the skin and take over that area. But because these tumors don't like to go elsewhere, there usually is not an indication for getting any imaging at the time of diagnosis. So you get the call from your doctor saying, this is a basal cell carcinoma. We're going to refer you for this treatment. But it is very rare for you to also get any sort of imaging like a CAT scan or a PET scan or even an X-ray. Now, when would your doctor order imaging? They would order imaging if they are concerned about any underlying structures. So for instance, you can imagine if you have a large basal cell carcinoma near the eye, you may be worried that it's actually going into the eye. Maybe it's going behind the eye or involving the muscles behind the eye. And those are very much going to affect treatment decisions. Same with the nose. It can be going into the cartilage of the nose. It can be going through the nose. It's going to very much dictate what type of treatment you get if those underlying structures are involved. Basal cell carcinoma does have the potential to track down nerves as well, so certain imaging such as MRI may be useful in looking at those nerves depending on your clinical situation. Less commonly, we check the lymph nodes to see if it's spread. Again, those are going to be for very large lesions, usually greater than 4 centimeters, so about the size of your palm. And in those instances, your doctor may consider ordering some imaging to check to see if that basal cell has spread elsewhere, like your lymph nodes. Again, it is not indicated, but it may be considered. For the same reason, most basal cell carcinomas are not going to need any sort of consultation with medical oncology or even radiation oncology, because the vast majority of these lesions can be treated with local surgery, destruction, or creams. So let's talk about those treatments. What treatment should you get for your basal cell carcinoma? A lot of the treatment is going to depend on where the basal cell carcinoma is, what size it is, and what subtype it is, meaning what pathologic features did they see when they did the initial biopsy. So first, location. So generally, areas on the head and neck, hands, genitalia, feet, and even the front of the leg are high real estate, high priced real estate. And that's because you don't really want a big scar in those areas because it either can be cosmetically deforming or can actually affect how you use your face, hands, genitalia. And for that reason, we try to take the smallest margin possible. Now, the general margin for excision is 4 to 5 millimeters. Generally, when you take a basal cell out, you cut out with a margin. And so that can lead to a much longer scar than you're expecting. So even a basal cell this small can end up with a scar about that long because of how we have to lay it down flat. Now, on the back or the chest or the stomach, maybe that's not such a big deal, but on the face, especially near the eye, the nose, the mouth, all of those areas have to function. They do something for you. They keep your eyes closed. They allow you to breathe. They allow you to talk. And so you really want them to function as well as possible. Plus, it's in the central face and everyone's looking. You want the best scar possible. For that reason, at least in the United States, Mohs surgery is the preferred form of surgery for basal cell on the head and neck, as well as those other areas like certain parts of the hands, genitalia, feet, maybe the anterior part of the shin because it heals really poorly. Mohs surgery involves a procedure where we cut the area around the tumor and check it that same day while you wait. Usually it takes anywhere from 15 minutes to several hours, depending on how complicated your tumor is, how large your tumor is. If the margins are clear, then you know that day, and usually sutures are put in that day. If it's not clear, there's a map where we, as the Mohs surgeons, will actually look at the tissue under the microscope, map it based on how we took that tumor out, and be able to go back and specifically take out the tumor cells and leave the normal cells alone. Every time you go back, it does add some time to the clock, so know that, you're there half a day, a whole day, but most of the time you'll know that day that the margins are all clear, and typically you'll have sutures put in the same day. Now, this procedure is not available everywhere in the world. Different methods are used, but usually some form of surgery on the head and neck is used. The other benefit of Mohs surgery in particular is that the whole margin is checked. It's what's called en face sectioning. So the only thing you really have to know about it is it's a little bit of a different way of sectioning than, say, the typical pathologist would use. And the reason for that is it checks the whole margin, whereas the other form of pathology called bread loafing cuts through. It's really good for diagnosis, but not so good for checking margins. So which skin cancers, which basal cells are not great for Mohs surgery? So those on the head and neck or the hands, feet, scalp that are superficial type basal cell don't always need surgery. Now, you can cut them out with surgery. They have a 99% cure rate when you remove them with surgery. But if you look at the pathology form and it says superficial basal cell, that means that you actually have a few different treatment options. So aside from the Mohs surgery, you can consider topical therapy in a lot of scenarios. Topical therapy, though, is long. It can involve several weeks, 4 to 6 weeks, sometimes even longer, of a cream once or twice a day. The most common type of therapies that are used for basal cell carcinoma, including 5-fluorouracil, which is also called Effudex or Carac. And there's another one called imiquimod, which goes by the brand name Eldera, which you put on and it gets your immune system to kind of rev up and clear some of those basal cells away. Now, what are the benefits of the topical treatment? You avoid surgery, so you avoid the scars that are associated with surgery, the risk of bleeding, the risk of infection that go along with surgery. However, it doesn't always work. The literature shows maybe clearance rates anywhere from 60% to 90%, depending on the study. So it's possible it won't work for you. It also can have its own side effects. So these creams can cause redness, they can cause irritation, itchiness, they can cause hypopigmentation. But something you may want to consider and talk to your dermatologist about, specifically if the pathology report says superficial basal cell. Now, will these creams work for other forms of basal cell like nodular, micronodular, infiltrative? It's possible. Again, there are reports, case reports of these creams being used for these deeper skin cancers, these deeper basal cell carcinomas. They don't have great cure rates, but I have in certain instances used these creams for treatment of deeper basal cells with kind of mixed response. So again, something that I usually consider only in cases where surgery is really not going to be tolerated by someone. They're very elderly. Maybe they have a lot of other health problems going into the surgery. But generally, even very elderly patients with a lot of health problems can tolerate surgery because it's under local. It's lidocaine that's used. People do very well. And sometimes you tolerate sort of a one-day surgery with maybe a week of downtime much better than doing creams for weeks and weeks at a time with itching, redness, and pain. So something to consider. Other treatments for basal cell carcinoma, including destructive techniques where the doctor numbs it up and scrapes and burns. The benefit of these is, again, you don't have to go as deep. Usually there are no sutures put in. It can leave a decent scar. That's why we don't use it too much on the head and neck, and especially not the scalp, where it can destroy the hair follicles there and you're left with a nice little bald spot. So that tends to be used a lot more on the trunk, meaning the back, the chest, even the arms and legs. Again, best for the superficial basal cell, the type of basal cell that's not going too deep. Less effective for deeper basal cells, but it is still often used. And again, creams can be used on the trunk for those more superficial types of basal cells as well. Cure rate for a scrape and burn, also called an ED and C, for low-risk skin cancers can be upwards of 90-95% cure rate, so a decent cure rate. But again, you're not checking the margins. You don't know for sure that it's all out. And scarring can be pretty significant after these procedures, especially for very big lesions. So something to consider. You might not like the idea of stitches after surgery, but oftentimes the reason for stitches is to have the best cosmetic outcome that you possibly can in many situations. Now, I talked about how radiation and systemic chemotherapy are rarely used for basal cell carcinomas. Radiation, we sometimes will use for basal cell carcinomas that are very aggressive, meaning they have involvement of the nerves, or maybe they are going very, very deep and you can't get all of it out. Then we use radiation after surgery. Again, not very often, but a few times a year for very aggressive basal cells. So that's not something to expect yours to be, but if it's going very, very deep or it's difficult to get clear margins, then radiation may be considered in those cases. What about radiation instead of surgery? Radiation also can be quite effective for basal cell carcinomas, but here's a big but. Radiation is one of these treatments that looks quite good right after you get treatment. So you go for your, 15, 20 fractions, you go, every few days and you get this radiation, and maybe you have some redness a few weeks after, the tumor goes away. You have an 85, 90% cure rate. But as time goes on, the skin looks worse and worse and worse because that radiation has damaged the DNA in the cells all around that area that you got treated. So the skin looks worse over years and even can develop new skin cancers in that area. So who do I recommend radiation for as a primary treatment? Usually patients who, again, are not going to tolerate surgery at all or really don't want surgery and are elderly, because a lot of those cosmetic effects of the radiation are years down the road, 5, 10, 15 years later. So if you're very elderly and maybe 95 years old, you may not care what your nose looks like 5 years from now. Now, that being said, remember, this is not a one-time thing where you get the radiation, you're done. It's many, many treatments done over a period of time. So it's a lot of visits. So something to consider, again, especially if you're very averse to surgery for whatever reason, or there's a specific reason that surgery is not for you, you can consider radiation in those cases as a primary treatment, but just know that there are definitely some sequelae to your skin down the line. What about systemic medications? It is very rare for us to use systemic medications in basal cell carcinoma, but there are some instances that we use hedgehog inhibitors, which are specific for basal cell carcinoma. The most common ones are vismodegib, sonidegib. These are targeted treatments for basal cell carcinoma. You can take them at home. They shrink down tumors. They're very effective, but they have pretty awful side effects. They make you lose your sense of taste. They make you lose your hair. Usually people lose quite a bit of weight, and you can get lots of achy joint pains, myalgias, muscle aches. So not an easy medication to take, usually reserved for cases like this where the tumor is in such a large area, it cannot be surgically removed. It can't be treated with radiation. We use treatments like vismodegib and sonidegib for those purposes, as well as for patients who are developing so many basal cells that we can't treat them all. Those are most common in genetic syndromes like Gorlin syndrome, where there are so many basal cells that actually doing systemic treatment is the best. These are medications that can be used forever. Sometimes people can use them for a while and then go off and the lesions are cured and they don't come back, but that is not always the case. When these type of medications don't work, we also have PD-1 inhibitors such as cemiplimab available to use, a little bit less effective than vismodegib or other hedgehog inhibitors, but can be helpful in these cases where you have widespread basal cell carcinoma or metastatic basal cell carcinoma. Again, these instances are really rare. These are not to scare you and make you think that this is going to happen to you, but in a tertiary hospital, a Harvard-associated hospital, we see these cases several times a year. It definitely does occur. And so just to know that these medications are available, and at least in the United States, this is what we consider for very high risk basal cell carcinomas. What should you expect after your treatment for basal cell carcinoma? So a lot of it is going to depend on how susceptible you are to getting more basal cell carcinomas in the future. As I mentioned, once you've had one, the chance of having another in the future is pretty high, about 30 to 50%, depending on your age and your risk factors. So your doctor will likely want to see you at least once a year to check you head to toe. They may want to see you more, like twice a year or even more if you're very susceptible, if you have a syndrome such as Gorlin syndrome, if you have a transplant, like an organ transplant, or if you have a chronic leukemia that makes you more susceptible to developing skin cancers in the future. Obviously, if you notice a spot that develops before your visit with your doctor, you should make them aware, because the earlier these are caught, the better. And then things that you can do to make sure you minimize the chance of getting more skin cancers in the future, including sun protection. Obviously, a lot of times these are due to sun you got when you were younger, in your teens, in your 20s. However, everything you do now to protect yourself is going to help. If you wear a big hat, if you wear sunscreen, if you wear sun protective clothing, if you stay out of the sun between 10 a.m. and 2 p.m. when the UV index is highest, all of these things are really going to reduce the chance of you getting more skin cancer in the future. They are not going to reduce it to zero. What other things can you consider? You can talk to your doctor about doing a field therapy. There are creams that you can use that kind of peel off some of the bad damaged cells that have occurred from sun damage in the past. You can do light treatments called photodynamic therapy, which again, kind of kill off some of these sun damaged cells. They reveal beautiful new skin underneath, and they can reduce the risk of skin cancers like basal cell in the future. Now, they're not pleasant. It's like getting a bad sunburn for either of these, but they may be worth it, especially if you're getting several different skin cancers, more and more skin cancers where you have a certain area that's clearly been sun damaged. Oftentimes we'll see patients where the left side of their face has many more skin cancers than the right, usually due to them spending a lot of time in the car. Another option that we talk to our patients about is niacinamide. Niacinamide is a form of B3 vitamin. You can take it 500 milligrams twice a day. It's available over the counter. Don't confuse it with its cousin niacin, which is also a form of vitamin B3, but used for cardiovascular effects and does cause flushing. Niacinamide has fewer side effects. They usually are GI upset, stomach upset, but are generally well tolerated. The data is pretty good that it can reduce the incidence of skin cancers by about 20 to 25%, maybe less effective in immunosuppressed patients. However, definitely talk to your dermatologist or your physician about this as an option to reduce the incidence of future skin cancers. Where can you find more information? If you watch this video and you really even want more information about basal cell carcinoma, there are some patient support groups out there. One is Skin Cancer Champions. This is a new online forum for both patients of sort of all non-melanoma skin cancers, as well as their caregivers and physicians. So this is a great resource. There's lots of educational information. You can find out sort of what the state-of-the-art treatments are. I've included in the description here if you want to find more information about that. The other options are Facebook groups or different online forums where patients will often kind of discuss their experience with basal cell treatment, especially after Mohs surgery. There are a few Facebook groups I've listed here where patients kind of discuss what their experiences. A lot of times it's very, difficult to really understand or know. I think one big thing that I see patients do is they will Google what to expect after Mohs surgery, and they'll have this big picture of a forehead flap show up, and they think, oh God, is this what is going to happen to me? Now, there may be instances where you do need a forehead flap. That may be with your dermatologic surgeon, it may be with plastic surgery, but most of the cases are not going to be that severe, especially if you catch it really small. It may be a larger scar than you're expecting. However, they're not going to be these worst case scenarios that you see on the internet in most instances. But I think what you can sort of get out of being part of these forums is really to know that generally the outcomes are quite good. So even though you may look very beat up the week after surgery, regardless of whether it's on your face, it's on your scalp, it's on your body, you may say, oh my goodness, this long line of bumpy stitches is never going to heal right. In most cases, it just settles down and it disappears with time. It's difficult to believe that when that's happening to you. And so I think it is helpful to sort of have those other stories, sort of long-term outcome stories, to really know what to expect. And you can always ask your dermatologic surgeon for before and after photos. A lot of times they will have them. I know we have them in our office. If you're very concerned, some dermatologic surgeons, some Mohs surgeons in the US will work with a plastic surgeon as well. But you have to remember, for the most part, this is part of our bread and butter. Doing the reconstruction is what we do for a living. That being said, it's your nose, and certainly if it makes you the most comfortable, talk to your doctor about a plastic surgeon doing the repair after your Mohs surgery. Again, regardless of whether you end up getting surgery for basal cell carcinoma carcinoma or you get a treatment like photodynamic therapy or these topical treatments, make sure you ask your doctor really what to expect. I think a lot of these things can be surprising if you just get a prescription for the cream and walk out and all of a sudden turn bright red. You know, being prepared and knowing what to expect can really, really be helpful. If this video was helpful, please like it. Please subscribe for more videos like this on dermatology, on skin conditions and skincare. I'm Dr. Abby Waldman. Be well.